अथवा अष्टाविधशस्त्रकर्मीयम् व्याख्यास्यामः यथोवाच भगवान् धन्वन्तरिः. The Shastra Karma, the surgical procedures are classified into 8 categories in Sushruta Samhita. Comparatively, in Charaka, the Shastra Karma are mentioned as 6 types, and those are Patanam, Vedhanam Jaiva, Chedanam, Lepanam Tata, Prachanam, Sivanam Jaiva, Shadvidam Shastra Karma Tata. In Sushruta Samhita, Chedana, Bhedana, Lekhana, Yeshana, Aharana, Visravana, and then Sivana, the varieties, the 8 Shastra Karma are mentioned. Whereas in Vagbhata, in Charaka, the Patana is representing the Bhedana. Vedhana is of course the same. Chedana is also mentioned same. Lekhana is worded as Lepana, but of course there is a Patantara also, Lekhana as a Prachana is about the Raktamokshana or Siravedha, the Vedhana again, as well as the other varieties. Sivana, the same as such. But for us now, it's about the Sushruta Shastra Karma, which is important. Now, Chedana is excision, removal of this abnormal tissue, which I think we have discussed in the previous session also. Now, the conditions where Chedana are indicated are Chedyaha, Bhagandara Grantihi, Shreshmika Stilakarakaha, Vranavatma, Arbudani, Arshaha, Charmakiro, Asthimamsakam, Shalyam, Jathmanihi, Mamsasangataha, Dalashindika, Snai Mamsasirakotha, Valmikam Shataponakha, Adhushascha, Upadamshascha, Mamsagandhi, Adhimamsakaha. These are just examples of the list of diseases where Chedana Shastrakarma is indicated or excision is indicated. In general, indications for the Chedana or excision would be Apakeshu to Rogeshu, in any of the diseases where the pathology is irreversible or it doesn't just end up in suppuration. That's non-inflammatory swellings. Katineshu Stireshuja, if there is the swelling is presented as a firm and fixed swelling, which again is a characteristic feature of neoplastic swellings. So, in pathologies which are irreversible and those like in neoplastic conditions, Snayakotha tissue, the dead tissues, the necrosis of the tissue, that's again a irreversible pathology. So, according to Sushruta, Chedana or excision is indicated in those conditions where the pathology is irreversible. Now, the conditions mentioned like Bhagandara, Granthi, Tilakaraka. Now, in these conditions again, it depends upon a specific stage of the disease. In Bhagandara, in a specific disease stage, like in Vataja Bhagandara, the lesions have to be excised. But it's not that in every Bhagandara case you need to have an excision. Or Granthi also, in the Granthi Chikitsa, you will come across these issues. In the initial stages, it has to be the Raktamokshana, which has to be Visravana, which has to be done. Only in the later stages, when it becomes Pakwa, it has to be excised. As in Pakwa Granthi, some Vataja or Pittaja Granthi, the drainage is required. Kapaja Granthi is the excision. So, when it is mentioned like a disease is a Chetyavyadi, it doesn't mean that every disease every patient presenting with this disease should undergo the surgery. It's about a specific stage in which that kind of a treatment or surgical intervention is needed. Whereas in the earlier stages or other stages of the similar disease, you have other options of the treatment. It could be initially the medical treatment, or it could be the other surgical treatment where there is no need to remove the tissue. So, removal of the tissue is the last choice in such conditions. We will go into each of these individual conditions somewhat in detail in due course of time. Now, Chedana or amputation, when you do the Chedana, the important is the instruments, the procedure of Chedana is involving with sharpest forms of the instruments like Mandalagra as a sharp instrument, and the instruments like Karapatra, the saw-like instrument where you can cut the tissue. Or it could be like Vruddhipatra, Nakashastra, Mutika, Utpalapatra, Sarani. Those two instruments which have a sharp edge, they are used for Chedana. And the definition of the Chedana is, in context of the Chinnavrana, you will come across that definition. If there is a separation of the tissue due to your sharp penetration, and the penetration could be either oblique or horizontal or vertical. Tirastinam rujuvapi yorunascha ayatobhvet gatrasya patranam, which results in patana or separation of a part of the tissue that's considered as a chinnavrana. So a chedana is to for the chinnavrana. So we can conclude that chedana is for the excision. Now, as I said about the in individual disease conditions, only in certain specific disease conditions, Chedana is indicated. In case of the Bhagandara, Adhistravi Bhagandara, that's the Kapaja Bhagandara, Utkriti Asrava Marganstu, Parisravani Buddhiman, Ksharena Asravratim, Dahed, Hutavehenava. Sushruta gives you the option of the excision of fistulectomy procedures in those conditions where the fibrosis is more and the discharges are comparatively lesser and there is a induration. In that condition, either it has to be excision or you have an option of a Kshara application or Agni Karma. So that's the point. The point is when a Bhagandara is considered as Chedya Vyadhi, it doesn't mean that every patient of Bhagandara should be subjected to the Chedana Shastra Karma. It's about that specific individual status which is the indication for the procedure. But ultimately, the last choice would be the Chedana. Similarly, with the Granthi, Amarmajatam Shamam Prayantam Apopameva Abharedvidaya Dahet Stite Aswaji Siddhakarma Sadyakshatam Te Vidim Vidadyata. A Granthi which doesn't get separated, or if it's located in a area which is not marma, where surgical handling is possible, even before it becomes pakwa, you can excise. It's only that option. You have the other options like Raktamokshana in the initial stages. We will come to that later when we go into the other surgical procedures. Similarly, Jatumani or Tilakalaka, Jatumani Samskritya Mashakam Tilakalakam, Ksharena Prahayitya Banya Vashaneshani. So, either excision of the Jatumani, keloids or barts or the hematomas or any of these melanomas, the lesions which are located in the body, which are suggestive of neoplastic conditions, and there is no suppuration, non-inflammatory swellings. Either they have to be excised or after the excision, they may have to be subjected to Agni Karma or even otherwise. Many of them can be managed with Agni Karma. That depends upon the size and then the other complications which are presented. Then with the Shalya, that's the next indication. If there is a arrow, now we will discuss more about that when we go into the Chapter-25 in the next coming sessions. But if there is an arrow or any other foreign body which has protruded through the body and then removal of that protruded portion would produce more tissue injury, you may remove that portion, that extended protruded portion of the arrow or any of that foreign body and then pull out. So this is one of the techniques of changing the shape of the foreign body which has got in. In that condition, Uttumitam Chitva Nirghate Chedaniyamukham. If there is a arrow which has protruded through and then has gone out, gone to the other side of the body, when you pull out that arrow, if there is a possibility of more injury, that extended portion of that arrow has to be cut off. So the total target is to minimize the tissue injury. That's the idea of chedana in case of a shalya, a foreign body. It's not the chedana of a body portion, it's the excision of the shalya which has got extended, but still it's included in the chedana shastrakarma. This way, if we go into all the indications, it is the same. In the contemporary surgery too, excision is one of the most important procedure of the surgical conditions. And the indications for the excision are irreversible pathologies. That's exactly the same as what Sushruta has said. Irreversible pathologies where you cannot reverse the lesion, as in case of the neoplastic conditions or in case of the necrosis of the tissue. Necrosis of the tissue and the neoplastic conditions are primarily irreversible conditions. In addition to these, now you have a few more indications. The dispensable organs and prophylactic resections. These are the two indications. Dispensable organs in the sense, if organ removal of an organ doesn't produce a significant problem or residual problem to the patient or the defects produced due to that removal of the organ is not significant, then that can be removed. Like in case of appendicitis. Appendicitis is an inflammatory pathology and it is not irreversible. It is reversible. But still, appendixectomy is one of the most common type of surgery being done because removal of the appendix doesn't produce significant harm as such. So, because that what organ is dispensable, it can be removed. Now, if you go into the history of contemporary surgery, the cholecystectomy history is very interesting. Up to about the late 19th century, gallbladder was considered as a indispensable organ. Gallbladder was considered as a very vital organ. And the removal of the gallbladder was not yet practiced at that time. And patients of gallbladder stones, gallstones, were treated with the cholecystostomy, removal of the gallstones only and then preserving the gallbladder. But what happened is Rutherford, one of the American surgeon, he accidentally, somehow, technically, there was a technical error, and accidentally he removed the gallbladder of a patient accidentally, and he was nervous, like what would happen to the patient in the post-operative period. But interestingly, that patient recovered very well without any complications, and during the follow-up also the patient didn't have any complications, and then that led to him to consider that gallbladder is dispensable, and at that time, against the ethics of surgery of that period, he did remove the gallbladder of a few of the patients without mentioning that and maintained that record. And when he presented that data of the gallbladder removal, the whole medical world had just attacked him, and virtually he was excommunicated. But later on, again, there was a revision of that data, and then the people accepted it. And now, from 1920 onwards, cholecystectomy has become a normal usual surgical technique, and cholecystostomy has become obsolete. So this is about the dispensability of the organ. Sushruta has not considered this view. In Sushruta, no organ of the body would be considered as dispensable, and it's only in those conditions where there is no other option that organ has to be removed. Then comes the prophylactic, removal of an organ before the disease has occurred so that the disease doesn't occur. I'll come to that part a bit more later. Later on, I'll come to that part. Now, when it is the excision, now in the contemporary practice, in the surgical practice, excision could be either a simple excision or marginal excision, where the lesion is removed exactly at the margin as such, or it could be intralesional, a part of the tissue lesion could be removed, and part of the tissue may be left over. So, or it could be wide excision, where it could be beyond that area of the involvement. Along with that area, a small area of normal tissue also is removed, or it could be radical excision, where the same organ, the whole organ which is involving, would be removed. This depends upon the possibility of the disease extending or recurring later. A highly malignant lesion like osteosarcoma, it's preferred that it's a radical excision which is usually preferred because there is a high chance of recurrence. A moderately malignant lesions like carcinomas, it's the wide excision which is preferred. A benign lesion, it's the marginal excision is preferred. If there is an inoperable condition and it is a debulking, the size of the lesion has to be reduced, and then you try to follow up with the other treatment, supportive treatment, where the condition is inoperable. Then intralesional excisions, like part of the lesion is removed so that the impact on the body is reduced. Then whatever is left over, that can be managed with the other supportive therapy. So this way, the excision procedures could be of different degrees, different approaches, depending upon the type of the lesion. And these kinds of the notions also were known in Sushruta. Sushruta has described these aspects of the excision in different contexts. When it comes to the context of Arbuda, Sushruta has specifically mentioned about the radical excision, where the arbuda has to be removed completely, and if even a small piece of that is left over, it can recur. Sashesha doshani yu arbudani karoti tasyashu punarbhavanti tasmat asheshani samudharetu hanyuhu sasheshani yatha hi vannihi. So even if a small piece of that or a small cell of that arbula is left over, it can result in recurrence. So that idea of radical excision is not absolutely new. It was known in Sushruta, but this is not explained in the same chapter as that of the Chedana-shastrakarma, but we will come across this description in the different contexts as such. Debulking resection and follow-up of the adjuvant therapies. This also is originally Sushruta's idea. This is described in the context of the Medoja Arbuda condition. Medasamuthe Tilakalkadigdam Datva Uparishta Digunam Patantam Hutash Taptena Muhu Pramjat Lohena Dhiman Adahan Vidaya Pralipya Darvi Matha Lakshayava Prataptaya Svedana Masyakaryam Nipatyaba Shastram Apokya Meda Dahet Supokam to Ataha Vidarya Prakshadya Sutrena Tilehi Supeshte Suvarchikati Harikala Mishtehi ससैन्धवैः क्षौद्रवृतप्रगाढैः क्षारोत्तरैः एनम् अभिप्रशोध्य तैलं विदध्यात् विकरञ्जगुञ्ज वंश अवलेख इंगुदमूत्रसिद्धम्. In case of Medoja, because the size could be quite huge and a complete removal can be harmful to life, can be fatal, Sushruta suggests a part of that could be removed and whatever is left over can be managed with the other medications like Taila, Kshara or so on. Or it could be the other way, a partial excision with the other way also, like if there is a huge bulk condition, in that condition you may induce the maggots. That induction of the maggots to have a debulking is a unique idea of Sushruta. And after the maggots have removed a huge portion of that, later on you may go for the surgical excision. So in case of again Medoja Granthi, again the same is mentioned, like लेपं विदध्यात् अत्र क्रमेयो यथा अत्र मूर्च्छन्ति मुच्यन्ति अथवा मक्षिकाश्च अल्पावशिष्टे क्रिमिभक्षिते तु लिखेत् ततो अग्निं विदधीत पश्चात्. So after the maggot formation, maggots have removed or reduced the size of the tumor, then whatever is left over could be either treated with Agni Karma or it could be excised. So debulking with the other way. Now in the present day situation, the debulking could be in both the ways. Either a surgical debulking followed by chemo or the radiation, or the other way is you give either chemo or radiation in the beginning so that the size of the tumor is reduced and then go for the surgical excision. These options are depending upon the type of the lesion, location of the lesion and so on other variable factors. Now both these options were known to Sushruta. Sushruta had considered a debulking of with the surgical excision in the beginning as well as debulking of the surgical excision after some other palliative therapies. So this idea is originally of Sushruta. Now then comes the question of prophylactic issue. Now as I said about the prophylactic surgery is a relatively new concept in the Western surgery, but it has become very popular now. And if you consider the majority of the surgeries being done are done with an idea of the prophylactic approach. Like if a patient has these females in USA, more than 40% of the females in USA at the age of 40 have got their uterus removed with an idea of possibility of reducing the malignancy of the uterus, because after the age of 40 uterus has no utility. In the a few years earlier, in the almost late 20th century, the fad of mastectomy, removal of the breast tissue, also was quite significant. So on. So that idea is because you have a uterus, there is a possibility of malignancy of the uterus, you remove it. Or because there is a breast tissue, you remove it so that the malignancy doesn't occur. But this kind of a logic has a severe limitation. It can go to the extent of because you have a headache, you can remove the head and then you will not have the headache. But that kind of a logic is not really practically possible. Of course, still, if you look at the total statistic of the surgeries being done now, a large number of the surgeries being done are with a prophylactic view only. But of course, there is a statistics supporting this, so I will not go into that part. But there is a very interesting historical issue. Historical issue is in German Marines during 1898 to 1902, during that period, there was an order that every person, military person joining the Marines has to undergo appendicectomy, whether the patient had person had appendicitis or not. Appendicectomy was done with an idea of avoiding the absence of the people in the military due to the appendicitis. Incidence of appendicitis was quite significant at that time, and absence due to that was the reason. And for about 4 years, 1989 to 1902, this practice was there. And then, as they followed it up, they found that the total absence period of the military persons didn't get reduced due to the appendicectomy. Rather, it had increased due to some other reasons, and hence that order was withdrawn. So, prophylactic surgery, whether it is really useful or not, is really the question mark. And Sushruta and Ayurvedic surgeons would not prefer that prophylactic surgery as a issue. This is a point which we have discussed in the previous session also. The surgical conservatism. Surgical conservatism is the basic identity of Ayurvedic surgery, and this is the point of debate. Okay, we will stop at that part now, and whenever there is more opportunity, we will discuss those issues. Then the next surgical procedure is the bhedana. Bhedana is a incision and drainage. And Sushruta has described the indications for the bhedana. The bhedya vyadhis are bhedyaha vidradhayo anyatra sarvajata grandhayastrayah. The vidradhi, other than that of the Tridoshaja vidradhi. Because Tridoshaja vidradhi is considered as asadhya, it is not to be treated with the bhedana. But if you look at the Visravana, indications of the Visravana, again vidradhi is indicated, but that's about the different stages. Vidradhi in the initial stages, in the Amavastha, it has to be treated with the Visravana so that it doesn't reach to the Pakvavastha. So if at all it reaches the Pakvavastha, then the Bhedana is the option of the treatment. Similarly with the Granthi. Now Granthi, it could be either excised, Chedana, or it could be the Bhedana, or it could be the Visravana. You have multiple choices of the treatment, and that's the same point, like it all depends upon the stage of the disease. That it's not that every patient coming to you, it has to be incised, it has to be, you have to have a clinical assessment. Only at that specific stage that surgical procedure is indicated. And the other indications are agitoya visarpas, or something like cellulitis, bruddhayaha, the scrotal swellings, savidharikaha, vidharika is the axillary lymphadenitis, prameha pedaka, the diabetic carbuncles, or so on. Shofaha, in general, the inflammatory swelling, Vranashofa, Stanaroga, breast abscess, Avamantakaha, eye diseases, Kumbhika, Anushayi, these are also is the Vranas, which we have discussed in the Dushya Vrana, where there is accumulation, a deep-seated accumulation of the pus acid. Nadi Vrana, where there is a sinus tract. Vrunda, Pushkarika, allergy, these are all the diseases related to the throat and the teeth, gums. Prashak Kshudrarogas, majority of the Kshudrarogas, they are of inflammatory origin, and hence they require the separate this drainage treatment. Any of those disease conditions which results in the pus formation, the indication is Bhedana. Puputau, Taladuntajau, Tundigeri, Gidayusha, these are all the diseases of the throat. Bastitsada Ashmari Hetoho, in case of the bladder, if there is a stone, vesical calculus, the basti is also subjected to surgery, though basti is considered as a sabya pranahara marma. Now, in the present day situation, the drainage of an abscess or a incision and drainage procedure is done wherever there is accumulated fluid as a result of inflammation, and majority of the inflammatory conditions where there is accumulated fluid has to drain, and there is a very standard protocol of drainage, how to do the drainage, and it is called as a Hilton's method of drainage, which doesn't specifically say anything beyond this, like the opening has to be done in the area where it is the gravitational dependent and where you elicit the fluctuation to the maximum extent, and once you have drained, the cavity has to be opened, and some compartments in the cavity, they have to be broken down by inserting the finger, and then keep that drainage open for at least next 24 hours. This is the protocol of what we call as a Hilton's method of draining an abscess, which is very considered as a standard protocol. But Sushruta has described the same rather more practically in terms of yato gatim vidya utsango yatra yatra tatra travanam kuryat yatha dosho nadishtadi. You have to make an incision where the location of that the fluctuation is elicited to the maximum, and it has to be ensured that the pus doesn't remain inside by keeping a drain open as such. That's about the bhedana. Similarly, the next is the lekhana. Lekhana is a removal of the curative. And curative, you use different instruments. Those instruments which are used for lekhana and so on, we have already discussed in the previous session, so I will not go into that part now. The indications for the lekhana are lekhya chatasro rohinyah kilasam upajihvika medojo dantavidarbha granthir vatmadhijivika aṣṭavidhaśastrakarmīyādhyāyaḥ mandalam mamsakandi mamsannatistatha. Rohini, Kantarohini is the diphtheria-like conditions. In the diphtheria, there will be a false membrane, a pseudomembrane, which blocks the respiratory tract in the throat. So trachea tends to get obstructed. And Sushruta had suggested the removal of that tissue so that the trachea gets reopened. But I would not suggest same in a patient of diphtheria, because chances of getting a diphtheria now is lesser, because it's almost now, because of the immunization, incidence of diphtheria has become almost nil. Still, it is not declared that we are diphtheria free. But anyway, by chance, if at all get a patient of diphtheria, now with the current knowledge, it's better not to handle that pseudomembrane. Instead, that respiratory obstruction can be managed with the tracheostomy, because handling of that pseudomembrane can increase the chance of toxemia. Anyway, during Sushruta's period, this kind of idea of tracheostomy was not in vogue, and hence, as a life-saving measure, Sushruta had handled the pseudomembrane and opening. So, logically, it looks perfect, but the issue is of the possibility of a toxemia developing after the handling of the pseudomembrane, and because you have a better, safer option now, which is established, like the tracheostomy, is the current treatment. Then similarly, the lekhana, the curating is done in case of the skin disorders to identify the pathology. So in the present situation, curating is done either to treat or for diagnostic. The diagnostic purpose, a small piece of the tissue is removed and then it's subjected to the test. And in case of the skin diseases, it's a very common practice. So kilasa is that kind of a skin diseases like, or it could be upajishvika, the throat, pharyngitis like conditions. Dantavidarbha, medodha dantavidarbha, where there is a hypertrophy of the gums and then gums would be covered up. Even now, the treatment would be curated. Hypertrophy of the gums, the treatment is the same now. Virtually, it's curated only. Of course, now we may use electric cautery for the curate as such. Now, granthi is, lekhana is indicated even in case of the granthi. And in case of the karpaja granthi, it's indicated, particularly is about the netra granthi, vartma granthi in the granthi, or and adhijvika, again the woolitis like conditions. Arshams, it's the charmasha, the skin warts, curating is indicated. Mandala is again the skin disease, the mandala kusta, skin disease. We are not going to that detail now. Mamsakandi and Mamsanati are the palatine masses in the palate. These also are treated with the curating. Now, of course, curating is done for the diagnostic purpose, or it could be therapeutic purpose, or it's a palliative procedures. The most common type of the curating done now is for the uterine endometrium, which we know as D and C, dilatation and curating. It's for maybe all the purposes, diagnosis as well as therapeutic or palliative purposes as such. Then comes the vedhana. Vedhana is a specific procedure where you drain the fluid with a narrow opening. Now, or it could be even for the blood vessels, bloodletting. So, vedhana has two meanings. One, it could be drainage of the fluid of accumulated cavity, and it can be reduced as such. Now, as a secondary option for the bhedana, incision and drainage. So, if the fluid pathology is such that there is no need of either complete removal of the fluid or a complete removal of the fluid is not possible, there is always a possibility of recurrence, or if the patient's condition doesn't permit a open drainage, incision drainage, because incision drainage is a somewhat more rigorous procedure, you aspirate the fluid, insert the needle and aspirate. So that's in case of Mutra Vriddhi Udakodara, Jalodara, abdominal fluid conditions, ascites conditions, Mutra Vruddhi in case of the hydrocele condition also, Sushruta had suggested the Vedana. But major chunk of the Vedana used by Sushruta was for bloodletting from the vessels, Siraha, Ratamokshana as such. Ratamokshana, the basic principle of Ratamokshana is Avagade Garokasya, Tachanam Pinditaitam, Sira Anga Vyatake Rate, Shunga Alabut Pachistide. In the Ratamokshana, if there is a deep-seated localized lesion, then Jaroka is preferred. If there is a indurated lesion, then Tachana, that surgical incision is done. Anga Vyapake, when there is a systemic pathology, Sira Mokshana, Rata Mokshana is the specific indicator. And Sushruta has given very clear-cut limitations of how much the blood can be removed and the limitations are. Balino Bahudoshuse, Vayastasya Sharirinaha, Param Pramanam Ichandi, Prastham Shonita Mokshane. It should not be more than one prastha. And the prastha can be something like 250 ml. That's the maximum limitation. Of course, you may have a lot of confusion like what's prastha. It's ranging from 200 to 400 ml according to different experts. Shilavedha Chikisardam Sharitandra Prakirtila Yatha Pranihita Samyak Bastik Kaya Chikiside. Shilavedha was quite popular in Sushruta's period, and in the Sharitandra, a large number of patients are being treated with the Shilavedha. Now, Shilavedha is described in case of Vedhana as well as in case of the Visravana indications. Visravya Vyadhis, which we are going to read next, can be even managed with Shilavedha. Because if it's a Anga Vyapaka or if it's a generalized disease, then Shilavedha is indicated in case of Visravana. Visravana is again all the varieties of the Rattamokshan included in Visravana. So there is no need of confusion about that Vedhana and Visravana. Anyway, the point which we have discussed there about this Vedhana or Rattamokshana, we have discussed this earlier also, that in the Western surgery, that bloodletting with venesection was very popular, and there was not much of a regulation. I think we have discussed that issue in the previous sessions also. And the history is like it was very popular, but the technique was, of course, barbers were the phlebotomists at that time, and those surgeons of that period also as barbers. And unfortunately, that's another very interesting issue. In the Western, I think that's a point which you have discussed in the earlier session also. The surgery was in the hand of the barbers in the Western side, and unfortunately, some of the experts, so-called experts from India, from modern medicine side, they have written an article. I have gone through an article in some newspaper where one of the experts in modern medicine had written that Sushruta also was a barber. This is their ignorance as such. Sushruta, you do not know the heritage of the Ayurveda, and you dare to write that Sushruta was a barber. Anyway, these kinds of issues will be there throughout the ignorance, but anyway, that's something which is not directly related to the topic we are discussing. Anyway, in the Western surgery, too, venesection was quite popular till George Washington died due to the excess of surgery. That's a point which you have discussed in the previous session, so I will not repeat that. And veterinarians also had practiced the phlebotomy in the Western surgery. Even now, it's practiced now. Veterinarians still practice venesection more commonly. And leeches were commonly used in 19th century as such. That's about the Visravana, Vedhana Shastrakarma. Then the Ashana is the probing, where you use a probe, soft probe to trace out the track, to feel the difference in the resistance. So it's either to feel the track of lesser resistance or feel an object where the resistance is more. As in case of the fistula, you follow the path of least resistance so that you will track that area. Whereas in case of a hidden foreign body, you will be hitting that foreign body with the probe, so where you feel the increased resistance. Now, indications for the Ashana, Ashyaha, Nadyaha, where there is a tract like fistula or the sinuses. Aṣṭavidhaśastrakarmīyādhyāyaḥ Unmarginasti, where the track is having multiple directions. Unmargi, multiple directions, identify the track. or social just when there is a possibility of Shalya inside. To probe, Sushruta had used the instruments like Karira, Balanguri Bihi, Yashanya, Bayashe, Bishaka, or Chuchupa, Udakaji, Hishlakshni, Karirehi, Eshetutaha, soft substances like tender bamboo stick, or it could be hash, or it could be finger, which could be used for the probe. Of course, probing is still a practice, but because the probing is a blind procedure, there is always a high risk of some unwanted injuries, collateral injuries. Because probing is done blindly, unless your hand is trained good enough, there is a possibility of creating a new track, and hence probing is done only in the expert hands. As a alternative now, you have ultrasonography. Ultrasonography is a technology where again the difference in the density of the tissue is made out by allowing a ultrasound wave to pass through, and reflected ultrasound wave is received, and this instrument, that component of the instrument where the ultrasound wave is generated, still is named as a probe. So now, in the current practice situation, many of those indications where the probing is mentioned in Sushruta can be managed with the ultrasonography as a choice, where the risk of intervention in the body, risk of unwanted injuries, or risk of sepsis, these can be minimized. Then comes the Aharana Shastrakarma. Aharana, word meaning of Aharana is extraction. But the technique of extraction is something more modified in Sushruta than simply the word extraction as such. Aharyaha, Sharkaraha Tistraha, Danta Karna Maloshmari, Shalyani Mudagarbhascha, Vrtashta Nichitam Gude, the different varieties of Sharkara, Mutra Sharkara, Danta Sharkara, Karna Sharkara. The Sharkaras, that crystals which could be formed in the urinary tract, crystals which could be formed over the teeth, the tartar, or it could be the karna in the ear where the wax may become hardened. That may have to be removed. To remove that technique is aharana. Or danta karna, danta karna malaha. This wax which has not yet become solidified. When it has become solidified, it's called as sharkara. When it is not solidified, it's mala, danta karna mala. So it is the status of the same disease phenomena. Ashmari, the calculi in the bladder, or Shalya, any of the foreign body, and Mudagarbhascha, obstructed labor conditions, the extraction of the labor, the fetus, Vartyasthanichitam Gude. Now, Sushruta's technique of extraction was not directly pulling out the presenting part, instead going behind the object and pull out. The removal of the teeth, now if you go to a dentist now, they will use a lion's forceps and hold the visible portion of the tooth and then pull out. Whereas Sushruta's technique would be use a hook-like instrument, and that hook would be inserted to the base of the tooth root and then extracted out. Now this is a safe idea, but technically difficult. Go behind an object and pull out is a safe idea, but quite difficult. Even in case of obstructed labor, in the protocols of dealing with obstructed labor, Sushruta had not used the forceps of the present day, Garbha Shanku. A hook-like instrument was used, not the forceps which we use now. In the present day situation, for the obstructed labor, if you have to use the forceps, that forceps is having simple a holding structure and the presenting part is pulled out. Whereas Sushruta's instrument was a hook-like instrument which will go towards the distal portion, and then whole fetus will be pulled out, which is quite difficult. But this kind of a technique has a inbuilt safety, and that kind of inbuilt safety is one of the advanced technologies in the present day situation, and that kind of a technology is called as a Fogarty's technology. Very popularly, Fogarty's technology is used in many contexts. Now, very popularly, it's used in case of the coronary artery disease for that coronary clot removal. Now, you use a Fogarty's catheter, and that Fogarty's catheter is inserted into the vein or artery which is blocked, and at the area of, it's negotiated beyond the area of the clot, and then that Fogarty's catheter has a inflatable balloon, and once that balloon is inflated and it is pulled out, the clot is removed. So by this, your chances of clot disseminating or moving further is reduced. That safety technique of going behind the object and then pulling out, curving, is the basic idea of aharana of Sushruta. And now we have more sophisticated instruments of that sort where this procedure can be used with a still higher level of the safety. The concern of the safety is the issue of Sushruta. Now it still has become now more potentiated with the newer technologies as such. So that's the point which you have to highlight with Ahara. Similarly, the next is about Visravana. So now, as we have referred many times earlier, the Visravana is considered as Raktamokshana, where all the techniques of the Raktamokshana can be included. But of course, primarily Visravana refers to the surgical incision, like where you make an incision and then allow the blood to flow out. Indications are Sravyaha Vidhaya Panchasave Bhave Sarvajadate Kusthani Vayu Sarujashrapo Shofaha Este Ekadeshaha Palyamayaha Shripodani Vishudustam Jashonidam Arpudani Visarpasta Granthayastraditashe Trayastra Upadam Shahastanarogaha Vidarika Sushiro Galashalukam Kantaka Krimidandaga Dandavestaha Sopagushaha Shitardaha Dandapuputaha Pittas Kapajastosya Kshudrarogasta Bhuyashaha. Now, Vidhati, the indications is in the Bhedana as well as indications in the Visravana. Arbuda is indicated in the Chetana, whereas as well as the Visravana. Or Kushta is indicated in case of Lekhana as well as in the Visravana. Shofa is indicated in the Bhedana as well as the Visravana. And so on and so forth. Now, if you follow that, again, the same point which you have discussed earlier, it all depends upon the stage in which the patient is presented, and in a specific condition, you may have to opt for a specific line of the treatment depending upon the stage as such. So that's and among the indications for the diseases, Visravana has the maximum number of indications. Then comes the Sivana, the last of the option. Sivya is Sivyaha Medasamutrashta Bhinnaha Sulikita Gadaha Satyo Vranashyetiva Chalasandhi Vipashritaha. Sivana karma or suturing is done in deep-seated wounds where there is a possibility of dehiscence, and the primary, wherever there is a possibility of primary healing without any complications, then suturing is done. And that's what Sadhyavranaha. And wherever the possibility of dehiscence is more, like if the wound is located in Chalasandhi, in a moving part of the body, then the Sivana is absolutely indicated. Is contraindicated in Naksharagni Mishirjusahanate Markabahinaha Nanta Lohidasandhyastra. If there is a wound which is contaminated with the objects like Kshara, Agni, irritant substances, or Visha, poisonous substances, if you close the wound, that's of course that irritation will continue and hence it should not be treated. Or Mardabhahivrana, those wounds where there is a possibility of flow of the gas from within the body. I think we have referred to that issue in the earlier Dustavrana context also. Any of the wound which will allow the gas to flow out could be of two varieties. One where there is a gangrene, where the gas is generated. And obviously in the gangrenous conditions, because it is produced due to anaerobic organism, the primary approach to the treatment will be to ensure that the area tissue will have the maximum exposure to the oxygen, and hence keep that wound open is the primary approach instead of keeping it closed. The other way is if there is a wound which is connected to the respiratory tract, or it could be connected to the gastrointestinal tract. When there is a gas moving out, that always suggests of a distal obstruction. And once you have cleared the distal obstruction, that wound will heal spontaneously. So in a patient who has a fecal fistula after the abdominal surgery, if the patient has a fistula there and then there is a leakage of the gas through the wound, the correct option would be you ensure that distally there is no obstruction. You have to explore and the distal obstruction has to be removed. Once the distal obstruction is removed, the wound will heal spontaneously. Instead of that, if you attempt to close the wound where there is a gas leakage, there will be an increased sepsis. The substances will spread into the peritoneum and the complications could occur. And hence, that suturing is contraindicated even now. That's a very perfect clinical assessment as such. Or Muralidhara Sharma, hematomas, where there is a blood clot inside, or any of the foreign body source of irritant inside, then if you close the wound, that again can result in more complications as such. And in such conditions, तेषु सम्यक् विशोधनं. You have to clear those these distal obstructions or that collected source of inflammation within. And as Sushra said, पांशुरोमनखादीनि चलमस्ति भवेत् चेत् आहृतानि यतो अम्मूनि पाचयेयुः भृशं व्रणं रुजश्च विविधा कुर्युः तस्मात् एतान् विशोधयेत्. Primary approach has to be, you have to ensure that all that debris or whatever that source of irritation has to be removed, and only when it has reached to that stage where a primary healing is possible, suturing is to be done. And now Sushruta has detailed the techniques of suturing as well as the instruments for suturing in detail. We will continue this in the next session.